This is chest imaging number 6, prepared by Prof. Sharaf, revised by Prof. Surya Sabri. Again, still we are in the mediastinum. In this case, we have bilateral hilar. Hilar means tracheobronchial, and there is right paratracheal lymphadenopathy. The differential diagnosis include lymphoma, leukemia, sarcoid, and deposits. So we have middle mediastinal masses. Differential diagnosis could be carcinoma, lymphoma, metastasis, tuberculosis. All of this, of course, will present as lymph nodes, and could be pulmonary artery aneurysm, and on top the sarcoid. Lung carcinoid. Carcinoid is a small, low-grade neuroendocrine malignant bronchial tumor, which presents with bronchial obstruction and calcification. It is functioning, means it releases histamine, serotonin, bradykinin, prostaglandin. Carcinoid syndrome, if the tumor is present in the ileal lobes, it's called ileal carcinoid tumor. This is predisposed to what's called as carcinoid syndrome, composed of cutaneous flush, diarrhea, and bronchospasm, and cardiac failure. Cardiac failure here is due to endocrinal fibroelastase due to serotonin. But bronchial carcinoid rarely cause this syndrome, but cause Cushing syndrome or hyponatremia due to ACTH or the vasopressin excretion. In this case, we have calcific tumor obstructing this bronchus, causing mucus bronchogram and consolidation. Bronchial carcinoid. Tumors with calcifications and distal segmental consolidation. Functioning in the lung, it may be associated with Cushing or hyponatremia. If it is ileal, it may be associated with carcinoid syndrome, composed of flushing, bronchospasm, and endocardial fibroelastase and heart failure. Benign, very vascular, hilar and paratracheal lymph nodes, usually in middle age, may displace the internal mammary artery as seen in angiography, and the differential diagnosis is lymphoma. This is called Castleman mediastinal or hilar lymphadenopathy. Here in this case, there is a right cardiophrenic angle mass. Of course, this is fat. And pericardial fat may be abundant, as in Cushing syndrome, and in those who are on steroids. This is called the right cardiophrenic bed of fat. Here is the mediastinum with large paraesophageal, lower posterior mass, which is supposed to be hiatal hernia, and in this case there is air delineating pulmonary artery, and this is pneumomediastinum. Of course, these are two different cases. Here we have right anterior mediastinal mass of mixed density and peripheral calcification. Anterior mediastinal mass with calcification, not connected to the thyroid, and it is not characteristic of lymphoma, and the appearance is that of a thymoma, as the calcification are peripheral, while in teratomes, either benign, immature, or malignant, the calcifications are usually central. But here there is another presentation, that is myasthenia gravis. Myasthenia gravis occur in 40% of patients who have thymoma, and thymomas occur in 15% of patients with myasthenia gravis. In the plain film, it is evident that you have a right parahilar mass of continuous margin, excluding that it is lymph node, and here it is rather well defined, partially obliterating the anterior retrosternal air, and CT is a mass with some enhancement, showing calcifications with some enhancement, and on MRI it is definitely with vascularity and edematous. It is intensely enhancing. It is intensely enhancing on T1 weighted images. This is characteristic of thymoma. Thymoma is a hypervascular, inviting calcifications, and it is seen in the anterior mediastinum related to myasthenia gravis. Here is another case. On the left there is pulmonary artery dilatation, but this could be lymph node, could be bronchogenic cyst, could be bronchogenic carcinoma. So these are the causes of unilateral hilar enlargement. But a unilateral small hilum indicates usually hypoplastic small pulmonary artery, and if bilateral small, this indicates low pulmonary blood flow. Enlargement of the central pulmonary arteries, the reverse. There are 5 common causes for pulmonary arterial hypertension, in which the pulmonary artery diameter exceeds that of the descending aorta. The pulmonary artery diameter exceeds that of the aorta, descending aorta. It's pulmonary arterial hypertension. Causes are shunts, chronic lung disease, embolic disease, and primary type of pulmonary arterial hypertension, but on top of all, chronic pulmonary venous hypertension occurring in mitral valve disease. Here we have pulmonary embolism The pulmonary, a relatively common disease with high mortality and morbidity. X-ray may be normal. Subsegmental atelectasis, we find subsegmental atelectasis. Pleural reaction. Focal oligemia, this is called the Westermarck sign. And a wedge-shaped pleural-based opacity. Wedge-shaped pleural-based opacity. Hampton hump. So we have what are the signs of pulmonary, maybe normal, subsegmental atelectasis, pleural reaction, focal oligemia, and wedge-shaped pleural opacity. Impulse in pulmonary angiography is either a linear filling defect or a meniscoid density. Either a linear filling defect or a meniscoid density. So what is this? Here is the meniscoid defect, and here is the linear defect. And these are different cases of pulmonary embolism. Here we have wide mediastinum with calcifications. So wide mediastinum with calcifications means that this is sequelae of chronic mediastinitis. You can find dilated collaterals on the surface due to obstructed superior vena cava, and you can find the calcification denoting healing process. So this is the typical appearance of chronic mediastinitis. But sometimes you are faced by diffuse mediastinal widening. It may be smooth if there is blood or pus or fat. It may be lobulated as lymph nodes, bronchogenic, superior vena cava obstruction, germ cell thymoma, and METS. So, if it is smooth, think of one of the three: blood or abscess, blood, fat, blood, or abscess. If it is lobulated, it is lymph nodes. If it is irregular, it is bronchogenic carcinoma or other germ cell tumors, superior vena cava obstruction, thymus, deposits, etc. Here is the irregular outline in bronchogenic carcinoma, and here is the smooth outline in mediastinal abscess. Metastatic reticular cell sarcoma, seen as uniform bulge of the right and left paraspinal stripe with destruction of the pedicles, more prominent on the left side. The CT shows the destruction and the soft tissue extension, and this is metastatic deposit. Compression injuries result in aortic lacerations like this. You will find wavy outline of the aorta at the arch, and it is either intimal injury or swelling or laceration. And here we can find that there is widening mediastinum due to hematoma or something leaking in this area. Denoting aortic laceration. Aortic dissection is the disruption of the plane between the outer and middle third of the media as a result of congenital weakness as in Marfan, or acquired cases as in atherosclerosis and hypertension, pregnancy, aortic stenosis, or traumatic. In traumatic dissection, 95% of tears occur near to the aortic isthmus, whereas the ligamentum arteriosum attached. Classification, we have the Stanford and the Becky. Stanford, type 1, ascending aorta, type B, ascending aorta is not involved. The Becky, type 1, ascending and arch and descending, type 2, limited to the ascending, type 3, limited to the descending, and the treatment is either medical or surgical accordingly. Here you can find the intimal flap and the change of caliber between the ascending and the descending. Normally the descending is less in caliber than the ascending. Here it is more apparent that it's larger. Definitely there is very big unfolding of the aorta and widening of the superior mediastinum, indicating an underlying aneurysm. More than one intimal flap, one here and one there, with mural hemorrhage, with intramural hemorrhage. Aortic aneurysm is defined as the enlargement of the aortic diameter greater than 5 cm. Atherosclerosis is the most common cause. Post-traumatic cystic medial necrosis is another. Post-traumatic is another cause. Cystic medial necrosis, Marfan's or Ehlers-Danlos. Arthritis of the mid-sized arteries and big-sized arteries, Takayasu and giant cell arthritis. Mycotic as intravenous drug abuse, endocarditis and surgery, syphilis and congenital anomalies. This is the differential diagnosis of and causes of the aortic aneurysm. Aortic aneurysm, by definition, is dilatation more than 5 cm. Atherosclerosis, normally it is up to 3.8 cm. 3.8 to 5 is a borderline, and more than 5 is aortic aneurysm. Maybe atherosclerosis, the most common, post-trauma. Medial necrosis as Marfan and Ehlers-Danlos. Arthritis as Takayasu and giant cell. Mycotic as abuse or endocarditis and surgery. Lastly, syphilis and congenital anomalies. Congenital aneurysms. Now we have very big structure here posteriorly, displacing the trachea anteriorly and showing fluid level here. And during swallowing of barium, the barium rests sediment posteriorly in a very large viscous, sigmoid shaped, and here you have a fluid level, and here is another fluid level. Usually this appearance is of hiatal hernia, but this appearance is of achalasia. But if it is sigmoid dilatation of the esophagus, can produce such things. Achalasia is disorganized peristalsis and failure relaxation of the lower esophageal segment. With Chagas disease, it's usually common. And what is Chagas? It is infection with Trypanosoma cruzi. But achalasia is another famous congenital anomaly due to defective neural elements at the lower esophagus, as in young females. Tracheal narrowing. Tracheal narrowing may be either granuloma or non-granuloma. If it is granuloma, it may be non-infective as Wegener or may be infective as TB. And here we get subglottic trachea demonstrating submucosal thickening and luminal narrowing in Wagner's granulomatosis. Most common tracheal carcinoma causing narrowing, bronchial carcinoid, chondrosarcoma, and leiomyosarcoma. All of these can produce narrowing of the trachea or masses bulging inside the lumen of the trachea. Carcinoma, carcinoid, mucoepidermoid, and chondrosarcoma. Tracheal dilatation. Focal tracheal dilatation is uncommon and is almost invariably due to tracheomalacia as a result of intubation. Diffuse tracheal dilatation is a congenital anomaly of Moynier-Cohn syndrome or pulmonary fibrosis, interstitial pulmonary fibrosis, and congenital tracheobronchomegaly. This is the appearance of the tracheal dilatation, tracheobronchomegaly, associated usually with bronchiectasis, also with bronchiectasis. So tracheal dilatation could be a part of another disease, focal disease as intubation, or maybe diffuse as a combination with interstitial pulmonary fibrosis and congenital dilatation of the trachea and the bronchi. This is the appearance of dilated trachea, tracheobronchomegaly, and this is often associated with bronchiectasis. And this is the last for the mediastinum. Thank you.